Well, today we have the privilege of speaking with Dr. Joseph Cullen. Dr. Joseph Cullen has a wonderful paper out recently around the implications of a high dose vitamin C and metastatic cancer. And I'm sure we'll dive into all the details of that today. First question is sort of bringing back to your background, essentially, of how did you end up in this in this very niche field?
Well, our lab has been investigating pancreatic cancer and treatments for it for 25 plus years. And about, I don't know, 18 years ago, we had Mark Levine from NIH came to discuss high dose vitamin C. And what he showed quite nicely was that if you give oral vitamin C, you get micromolar levels in the blood. But if you give it IV and larger doses, you get millimolar levels in the blood. And this goes way back to Linus Pauling in the 70s, saying it was a treatment for cancer. They did some studies with a Scottish surgeon, actually, and showed some promise. Then there were two large randomized trials from the Mayo Clinic using oral vitamin C, and they didn't work. So vitamin C as a treatment for cancer was dropped for a number of years till Mark Levine at NIH looked at the pharmacokinetics of vitamin C. He also did some cancer cells, and he showed quite nicely that the high doses of vitamin C did not kill the normal cells, but actually killed the cancer cells. So he came and gave a talk because he was collaborating with one of my colleagues here at Iowa, Gary Bittner. And his talk made a lot of sense to me. And we tried it in the lab, and it worked better than anything we'd tried before. With, minimal side effects. It was easy to administer. We did it, in cells, and we did it in mice. And then we did a phase 1 trial and showed it was safe and tolerable in patients when they got chemotherapy too. And so that led to a number of other studies that have been published, and then led to our phase 2 randomized trial, which you touched on.
I mean, it's a super fascinating approach to cancer, and I imagine initially has been met with a lot of resistance. Maybe skeptics might say vitamin C is a supplement, vitamin C is orange juice, and a lack of understanding of what vitamin C is and how it works, and I guess the very specific detail of how this actually has to be implemented to be effective. Could you speak to the misconceptions around high dose IV vitamin C and where people usually go wrong with it?
Sure. So the public thinks that vitamin C is an antioxidant, and at oral doses it is. And you can consume as much vitamin C as you want. You're still only going to get micromolar levels in the blood because the body either excretes it through the kidneys or doesn't absorb it in the gut. It's very finely controlled mechanism in the gut for levels of vitamin C. However, when we give it IV, and we give like 75 to 100 grams IV at one time, which is quite a bit higher, we get millimolar levels in the blood. And at millimolar levels, vitamin C becomes a pro-oxidant. So it actually makes reactive oxygen species, specifically hydrogen peroxide. And it's the hydrogen peroxide that kills the cancer cell.
I saw a meme which helped me understand this in prep for this, which is essentially, my understanding is the hydrogen peroxide, vitamin C almost houses the hydrogen peroxide as a Trojan horse into the cancer cell, as a very rudimentary understanding. Would you say that sort of analogy is correct, or that not so right?
Yeah, it generates hydrogen peroxide, and yeah, it's a pro-drug for the delivery of hydrogen peroxide. That's what some people have said. And cancer cells can't handle it, but normal cells can.
Okay, so as a good benchmark, the understanding is this would be classed as what we call a redox therapy, in the sense of it's non-toxic for the body, but it is toxic for the cancer cell, right?
Well, a redox chemistry is a reduction oxidation chemistry, which is what it is. That has more of the biochemistry behind it. But Yeah, there's very few side effects when you give it IV.
Okay, wonderful. So your most recent randomized clinical trial, firstly, can you describe the goals and the design of the trial and sort of how a patient selected, the outcomes you were specifically looking to measure?
Sure. So when we applied for this large grant at NIH, we were told we had to do a randomized trial for pancreatic cancer. So in one arm, the patients with stage 4 pancreatic cancer get gemcitabine and Abraxane, which is a standard of care chemotherapy for stage 4 pancreatic cancer. In the other arm, people were either randomized to that or they were randomized to get the same chemotherapy. In addition, they got 75 grams of IV vitamin C 3 times a week. And we followed them. We looked at our primary goal was overall survival. Our secondary goals are progression-free survival and measuring quality of life parameters and looking at how much chemotherapy patients took.
Okay, wonderful. And what were the with regards to the dosage? It was 75 grams 3 times a week. Was that spaced out, or was that how was that
Well, we
implemented?
usually gave it Monday, Wednesday, and Friday.
Okay, and is there a reason for not doing it? I guess Monday, Tuesday, Wednesday. Why the space in the day?
No real reason. That's kind of how we've done it before.
Okay, fair enough. Fair enough.
Yeah.
I guess before we go to results, what has differed between this trial and other trials you guys have done before?
Well, the big difference in this trial was it was randomized. So the other phase 2 trials we've done, including glioblastoma, and we're just finishing one up in lung cancer. Those were phase 2 trials, large number of patients. However, they were not randomized. So they were compared against historical controls. And they do show promise. They do show significant increases in overall survival. At least the brain cancer one has. The lung cancer one is not done yet. So those are very promising. But this was randomized. So half the patients got standard of care chemotherapy. The other half got standard of care chemotherapy and vitamin C.
Okay, and what was the conclusion of the study?
Well, the conclusion was we increased overall survival. We doubled overall survival. So patients that got chemotherapy lived about 8 months, median 8 months. And when they got vitamin C along with their chemotherapy, they lived to 16 months. So overall survival was significantly increased. Progression-free survival also increased. It went from like 3 months to 6 months. And
Sorry,
go ahead.
I was going to say, just for someone who's not familiar with progression-free survival, what does that mean?
Well, we follow the patients quite closely, and every 2 months they got a CT scan. So if their tumor got bigger or if they developed more metastatic lesions, that would be progression, and they would drop out of the study and then have and be offered another type of treatment.
Right. Okay. Understood. Well, I mean, those results are remarkable, and I'm sure you've been met with a lot of positive feedback since the study actually went live. A couple of weeks ago, right?
Correct.
What what does this change about how we view high dose IV vitamin C into oncology? What are the implications from this study? Does it mean we can start implementing this tomorrow, or is there still work to be done?
Yeah, there's still work to be done. At this point in time, the FDA has approved it for a nutritional supplement, but we're using it as a drug basically.
Mm.
And so we probably would have to do a phase 3 multi-institutional trial to get it in the clinic.
Okay. And what are the main misconceptions around high dose IV in conjunction with standard care?
Well, a couple of things. First of all, people think they can drink boatloads of vitamin C and they would get the same effect, and they won't. The other thing is a huge misconception by medical oncologists is they think that this IV vitamin C will reverse the effects of chemotherapy on tumor cells. They think of it as an antioxidant, and so it's going to reverse chemoradiotherapy in patients, and it doesn't. It's actually synergistic with or additive to most chemotherapies and radiation. So at those doses that we're using, it's actually synergistic. It's not reversing the effect.
Okay, interesting. I mean, as you said, it's pro-oxidant. It's a pro-oxidant in
Yeah.
those cancers, right, as opposed to an antioxidant. Okay, interesting. I guess you would never be allowed to run the sort of third variable of the study, which would be a group who are just having high dose IV vitamin C.
Yeah. No, you can't. It's considered unethical not to give standard of care at the same time. So,
What do you think about that?
you know, there are case reports out there with people just treating themselves with IV vitamin C, um, just vitamin C, and they've done fairly well. So it would be interesting to see, but I don't know.
Okay, understood.
We could never do this study.
No, it's always a frustration with these things. I remember reading a couple of other studies on some unrelated things to cancer and thinking, oh, there was a third variable there. That'd be so interesting. But alas,
Yeah.
you have to follow ethical implications. Um, if so, if you had to, God forbid, have a relative who had had, let's say, a metastatic cancer, and then another relative who didn't have a metastatic cancer but still had maybe a stage 2 or 3 cancer, but it hadn't spread. Would you, and they ask you for some advice, and they're a loved one, they're a friend, they're a close relative, would you recommend them pursuing a strategy including high dose vitamin C?
What I've been telling people is to talk to the medical oncologist and discuss it with them. And if the medical oncologist has any questions, they can contact me and we can send them our protocol. The problem is that here at Iowa, we can't give vitamin C unless they're in a trial. But there are plenty of alternative and complementary medicine practitioners throughout the United States who will infuse it. The other problem is that insurance won't cover it. So those infusions can get kind of expensive for patients.
Yeah, I'm sure. I guess I mean, here when I'm in the UK, right, and an issue with people who have cancer is they come across your paper, they're enthused, they're excited about the prospect of actually implementing this on their own or in conjunction with standard of care, but yet they go to standard of care and the standard of care are completely unfamiliar and haven't read the research and don't have any intention to read the research. So they're met with a pushback of, well, you can never explore that. What do you, what would you say to those people who are sort of trying to take agency over their own health and implement this? But yeah, met with pushback with standard care.
Yeah, well, the bad thing about vitamin C is it has a kind of a bad history with a lot of quacks using it for years. They never knew the mechanism. They had this mechanism and that mechanism. And if you look at our research, I mean, we have almost 100 papers on this, the mechanism of how this works. And we've studied it with NIH funding and federal funding. And so the mechanism is there. So we have the mechanism. And that's kind of one of the problems that exists with vitamin C is we're really kind of fighting a long history that is kind of up there with kind of quack type medicine.
Yeah, it's sort of any big innovation usually needs a rebrand in vernacular, right? I think,
Yeah.
Vitamin C's connotations of Tropicana orange juice, the layman, right? And it's not
Yeah.
quite the same thing. Maybe a push on, what is it? Ascorbic acid? Am I saying that right?
Ascorbic acid. Yes.
Ascorbic acid, yes. Okay. So I guess my next question is around the types of cancer that this would be beneficial for mechanistically, and maybe are there some cancers that are more favorable towards this in theory, and some cancers that probably wouldn't be as favorable for this?
Yeah. That's a good question. So what our group has studied is brain cancer, glioblastomas, lung cancers, and pancreatic cancer. And we've had good success with all those three. I know of other groups that are looking at multiple myeloma, which is kind of a blood cancer. And there's a group in University of Kansas they're looking at bladder cancer. A recent study just came out with late stage prostate cancer, and it showed that it didn't help at all. So but they really didn't have preclinical data to support doing it. So it's very important that they have preclinical data to support that it might actually work with chemotherapies that are involved in that certain cancer.
Right. Yeah. I mean, I imagine it's hard to standardize that everyone is doing it exactly the same way as well.
Mhm.
Very, very difficult. How would um, how would one go about uh, getting this essentially, or how accessible is implementing this if you did have cancer?
You'd probably have to go to, like I said, an alternative and complementary medicine practitioner, integrative medicine practitioner. I mean, they exist everywhere. There's one about 3 miles from here, that will infuse vitamin C. Um, and, you know, I'm not sure what the process is as far as how they do it and stuff like that, but they will do it.
Mhm.
You can find them anywhere.
And is there any difference between people who have cancer that it is metastasized, or people who just have cancer that hasn't? Would the outcome differ?
Well, we did one of our phase 1 trials was combining vitamin C with radiation in locally advanced pancreatic cancer. So it had not metastasized to the liver or anything like that. They were getting radiation and chemotherapy. And we have 3 long-term survivors from them, 3 out of 14. And when I say long-term, they're 9 years out and they're cancer-free.
Wow.
So that, to me, that's pretty impressive.
Yeah. And my understanding is pancreatic cancer is a pretty lethal cancer as well.
Yeah.
How is it sensible to extrapolate these cancers to other cancers, or in your view, or do we need studies for every single type of cancer?
Um, yeah, perhaps not every single one. But I guess I would say that if you're combining it with standard of care chemotherapy, it probably would be worthwhile to do some preclinical studies to see if the vitamin C is additive or synergistic with the chemotherapy.
Okay. Yeah. So I guess the next theme is, if someone's listening to this and they have cancer, the um, the problem is they might not trust their own interpretation of the literature over the well-intentioned but maybe um, not as well-informed oncologist. So the actual implementation of this on themselves they might hesitate, which is completely normal, right? What would you say to someone who is questioning if this is safe?
I would say it's safe. The biggest, I mean, in our paper, we outline the adverse events, and the adverse events were less than if you got chemotherapy alone. And one of the other findings we saw in the paper was that patients who got vitamin C were able to get chemotherapy at greater doses and for longer periods of time. So they tolerated the chemotherapy better.
Uh,
Um, and there were actually some quality of life parameters which were better with the vitamin C group. So I do believe it's safe. The the two biggest risks or problems with it is patients get very thirsty when they have an infusion because it's a huge hyperosmolar load, a big salt load. And the other complication can happen is they can get kidney stones. Now, we've been pretty fortunate. We've had only 2 or 3 patients that have had kidney stones in over 200 patients we've studied. So the risk is low, but it is there.
let's double click on the uh, vitamin C unlocking a higher dose of chemotherapy if needed, because I guess you can handle more of the adverse side effects. If I've heard you right. What is it mechanistically that basically keeps you more buoyant during chemotherapy with vitamin C as opposed to just with chemo?
So what our group has thought is that at high doses in normal cells, the vitamin C acts as an antioxidant, and in tumor cells, it acts as a prooxidant. And we have shown some very nice mechanistic studies looking at radiation and how radiation does damage normal cells. Well, when you insert parameters of normal cells, when you add IV ascorbate at doses that we use, it actually reverses the effects of radiation in normal cells. And it probably has to do with the lipid peroxidation mechanism.
Wow. Well, that's super impactful. Do you see IV vitamin C being part of standard care moving forward?
I don't know. It's gained a lot of interest, but I would argue, I would state that the medical oncology field is very reluctant and resistant to it.
Why is that?
I don't know. They don't. They are thinking in the past of the trials that were done in the 80s with oral vitamin C, and they didn't show an effect.
Right. It's super hard to change the guard of this field, especially with cancer.
Yeah, it sure is. I mean, it's insane. I mean, honestly, the number of journals that we sent this paper to before we got it published in Redox Biology was very discouraging.
Do you think perverse incentives might be at play?
Maybe. Yeah, maybe. I don't know. You know, the other thing about this is it's just the mechanism is so simple. It's so simple. It delivers hydrogen peroxide to the tumors. That's all.
Yeah, it's sort of maybe the traditional field that I think the divinity matters when all that matters was the Ten Commandments, right? It can't be so simple.
Something like that. I never heard that. That's pretty good though.
Well, yes. Hopefully, we'll see if it lands with the audience. Who knows? I speak to lots of people in the cancer world, studying various different niches, and what surprises me is that not a lot of them talk to each other. It's very siloed, and as a result, I don't know, it surprises me. And then there's always one common theme of it's super hard to get funding, and it's super hard to get these papers out there. And even when they're out there and they're published, getting people to actually read them, but the right people to read them, the people that could implement these on a wider scale. How do you think?
You know, you're exactly right. One of the first journals that we sent this to, I'm not going to say where it is, but it's in Boston, and they got it back to me, and they said, you know, usually in these type of studies, you do a survival plot over time. And I said, and I replied to him, that's figure 3. He goes, so he clearly hadn't read it. And the reviewer hadn't read it. And he said, oh, well, yeah, it's rejected anyway. So, you know, I mean, I know reviewers are busy. I review for journals. I'm on an editorial board. It's a lot of work. But come on, you know.
That's frustrating for you, I imagine. Is there obviously you've been studying this with cancer, right? And you said the mechanism is really simple. Is there any other chronic diseases maybe, or implementations of this that could be interesting down the line?
Yeah. So a couple of years ago, there was a lot of interest in using it in sepsis. You know, overwhelming infections. And they did a number of studies in ICU patients, and the results did not show that it made a difference. However, I would argue that they didn't give enough. They gave only, I think 10 to 20 grams or 10 to 25 grams IV every now and then. They didn't give it very often. And we're giving 75 to 100 grams IV 3 times a week. And we've given 75 and 100 grams every day if they are on radiation for 6 weeks. That was the study that I mentioned earlier. So I still think there's a mechanism there with sepsis. And I think the studies needed to be done with higher doses. So,
right. Just so, I mean, that's amazing. So 100 grams every day for 6 weeks. So even that's the upper limit, and assume that's all safe. Just in the study where you did 75 3 times a week, how many weeks did that go on for?
Well, in one patient, it went off all for almost 2.5 years
Wow.
because she lived so long. She never progressed.
Wow.
Yeah,
That's
in fact, the medical oncologist had to give her a break from chemotherapy because they'd never given this much chemotherapy for this long a time in a patient ever.
mm.
So we
Think
gave
any,
her like a month break, and then she came back and kept going at it. And yeah,
yeah. Hey, do any, I mean, my head goes to hyperbaric oxygen because there's some interesting research showing that it might help one go through or help one offset the negative side effects of standard of care. I mean, research debatable and all these things, but maybe interesting to explore further. Seems like this does a very similar thing where it offsets the negative damage to your healthy cells of standard of care. Is there any other things that you are interested to explore in stacking with this?
yeah. So our lab right now is looking at metastatic disease, and we've shown that in cells that are resistant to ascorbate. So we treat them with ascorbate over and over and over again, and then some of them live, and some of them live, and then we treat them again, and some of them live. If they're resistant to ascorbate, they metastasize much faster. So, and the mechanism of metastasis is altered quite a bit. So that shows kind of a mechanism that we kind of discovered using ascorbate that might be important in patients too in metastatic disease.
That's super interesting. The- I can see the excitement behind the field, and I can also see the frustration that you have that you've done all the hard work, and yet the sort of the for lack of a better term, marketing or distribution of this thing is part of the issue. Um, what what do you think needs to happen for this to be accepted on a wider scale?
Yeah. So here's an interesting story. When Mark Levine came and talked, and we were excited, and we did it in some preclinical studies. We wrote to our institutional review board, our human subjects board, we're going to do this trial. We wrote up the trial. We had funding for it. And the medical oncologist who was the head of it said, I have the letter. It said, these trials will never be done at the University of Iowa. So, we did them, and, another oncologist kind of made fun of us and tried to shut us down. And the results showed that it was working quite well. And we had one medical oncologist, a guy named Dan Berg, who was fantastic. He was open-minded. And he helped us the whole way. And now the medical oncologists, they have tons of trials here at Iowa, a lot of trials at Iowa. They're trying to throw it on any cancer that walks in the door. So, if you see good results, that will spread. That idea will spread, I think. But, we still see in other institutions that don't have any experience with that, this kind of negative attitude that we experienced, 20 years ago.
Yeah, I guess so. I know how much vitamin C costs as a supplement because I've from a professional point of view, I've bought it in commercial doses before, and it's cheap to my understanding.
It's really cheap.
And I
It's
assume,
ridiculously cheap.
right, okay. And I guess you wouldn't be able to patent that or
No.
commer right. So do you think that I guess the financial interests involved might be the reason behind why this isn't really taking
Yeah,
fold?
you hit the nail on the head. Yeah,
Right.
big pharma is not going to make any money on this.
Mm.
None at all. It's so cheap.
Mm. Well, I think a hopeful a hopeful side effect of your paper was I saw it pop up all over my feed, in my inbox, in some friends sent it to me. And even though it might not be, I don't know, welcomed by the sort of huge people who control a lot of funding, I do know that the community of these alternative therapies, if maybe for lack of a better term, does spread these things, and it is starting to spread further. Conversations like this, maybe they help in someone with big pockets and an interest in
Yeah.
funding these So you never know. Dr. Cullen, my next question for you is around your dream study, right? If you can wave a magic wand and there's no limits, you can have as many groups as you want, you can have as much parameters, it's your universe, it's your study, you can run it. What study would you most like to run?
I would love to do a phase 3 multi-site study looking at stage 4 pancreatic cancer with standard of care with and without ascorbate. Multi-institutional, like 4 or 5 institutions, a larger study. We've actually done the statistics or something like that. We probably enter about 96, maybe 100 patients. And one of the criticisms of our study, which I think is legit, is that, we did this in Iowa in 2 patients from Medical College of Wisconsin. But it's, Iowa's a very rural state, so we don't have much diversity here either. So in a more diverse population, it'd be great.
Okay, interesting. That would be a really cool study to go and see.
Yeah.
It sounds like it's the next progression from the one you've just done, though.
Yeah, it would be. But like I said, we have to, the cost of doing something that multi-institutional trial would be pretty significant, I think, but yeah, who knows? Maybe somebody will give us some money for it. I don't know.
So let's double click on the funding side of this, because I'm not familiar, but I don't think most of our listeners won't be, but I think it would be interesting to explore. I know that in the US, billions of funding per year thrown into cancer, but by the sounds of it, these kind of therapies don't get a lot of that funding. Where does a lot of that funding come from, and what's needed to, unlock more funding for the trial you just said?
Yeah, the drug companies are bankrolling it, basically. They have their special compound or drug or whatever, and they're funding the studies. I was actually just at FDA panel last week, and just the amount of money that goes into getting something through is just astronomical. We could never afford it. NIH, NCI, National Cancer Institute, actually funded this phase 2 trial, but they don't fund phase 3 trials.
Why not?
They just don't. They stated it. They don't do that.
Right. Is that from a good reason in the past? Is it conflict?
No idea. I suspect the cost of it. That'd be my guess.
Okay. Well, yeah, that's interesting. I guess I wonder what incentives have to be in place for these therapies to get more of that capital, because I guess if it's all drug companies, you can't anything that's not you can't commercialize. Just this sort of goes out the window, right?
Yeah, probably. They could get the patent on it. They could get an indication from the FDA on it, and they'd be the only ones supplying it. I think, I'm not a business person at all, but I would think that could be beneficial for some companies.
Mm. Yeah, I just think maybe it's looking the wrong way around, right? Maybe you reduce such a cost if cancer rates go down. So to society, so surely that should be an upfront cost worth paying. Dr. Cullen, what research, it can be within high dose IV vitamin C, or it can be within cancer, anything you like, take it however you like. What research are you most excited about over the next 5 years?
Some of these immunological drugs that are used now, I'm seeing some patients, actually a friend of mine, who had lung cancer, non-smoker, and she's gotten by 4 years where, 15, 20 years ago, it'd be 1 year survival. So some of these immunological drugs have shown remarkable properties and good long-term effects. There are a lot of side effects of these, though. There are a lot of side effects. And we've shown, one of my colleagues has shown quite nicely that vitamin C probably turns on these immunological drugs so they work better, actually.
Oh, wow.
Yeah.
That's interesting.
So that's one of our next areas of interest.
It seems like it's never one thing. It's always the right combination of things.
Yeah. Yeah. How true. Yep.
is bizarre. But then if that's true, then the siloed nature of medicine, it needs to be more multidisciplinary. How do you think about the field needs to communicate more, if at all?
Well, I would say that at the University of Iowa here, when we did our studies, we have the best collaborative team you could imagine. There's really no silos. All those people that were naysayers against vitamin C have all retired, or died or something. I don't know. They're not here anymore. And just it's just an incredible collaboration with our cancer center, our nursing, research nurses, and our medical oncologists, our radiation oncologists also. Just a huge collaborative team. And, I'm the one that's being interviewed, but there's just so many people behind me working on this. And I think that's a great model. I think it's a great model. And one thing that I've always said about the University of Iowa is it's a very collaborative nature. That's probably why I've stayed here my whole career.
I guess, open door policies are wonderful, whether, I don't know, business or it seems like in this world. And sometimes I have one episode and then I have another. I just want to get the two people to talk to each other and just be a fly on the wall and see what happens. Might be an idea for an episode, to be honest. What surprised you most about the work you've done over the last 20 years?
How well it's worked. It just, the more we do it, the more it just like, yeah, that works in this. And we've shown quite nicely that, in our phase 2 trial that it's effective in patients, but now we're investigating so many mechanisms of why it's, we know it's hydrogen peroxide, but all these other mechanisms, like I mentioned, the metastatic cascade of events, how it affects that, how it affects immunological drugs. All these other effects are kind of improving things, and how it reverses some of the radiation damage to normal cells. So we're looking at a lot of different effects that all add up to better survival, really.
Well, good. I mean, it's an important message to get out there. I think, obviously, interpretation of the literature can be, it can be varied, and especially with people who haven't had the training you've had reading your paper. I guess with that in mind, what would you like patients and families, fellow researchers, to take away most from your most recent work?
Yeah, they need to discuss these options with their medical oncologists, and each case is a little bit different. So, and each case is kind of an individual story itself. So, just talk to your treating physicians and see what is best for you.
Okay, wonderful. And I know you mentioned earlier that you have a lot of people's oncologists reach out to you with questions.
Yeah.
What are the most common questions you receive from oncologists?
How do you give it? How do you give it? Like the details, how much, what kind of infusion do you do? What kind of parameters do you look for? So I usually send them our protocol.
Right. And where can we find the protocol?
It was on clinicaltrials.gov for a while. I think it's probably still there.
Okay. Well, we'll find it. Clinicaltrials.gov. I always like that website. It's great. Very interesting to explore for anything you're curious about. See how many clinical trials in the world.
Yeah.
But we'll find that. We'll put a link to it in the show notes. You're an interesting person because you're studying something non-consensus, and you're met with a lot of heat of that non-consensus, but you keep going down that path because you believe you're right, which is, I think, is a very interesting position to take in life. So, commend you for your work. It's really, really cool. We will put that in the show notes, the protocol. We'll put links to your most recent paper and your work in the show notes. Any other resources you would recommend, or where we can find you? Any other resources you recommend to our listeners if they're interested in learning more?
The University of Iowa Free Radical and Radiation Biology program probably has links to all of our papers and our colleagues' papers that look into similar mechanisms in vitamin C, that would probably be a good link too.
Okay, wonderful, wonderful. Well, Dr. Cullen, that was really fun. I can't thank you enough for coming on. Loads, and I'm 100% sure our listeners will have a lot of value taken away from this. So thank you so much for coming on.
No, you're welcome. Yeah, it was fun.